You are at the download. It is MiHIN's convening a monthly webinar diving into the intersection of healthcare and technology, the intersection of healthcare, technology, policy, sociology. It is a fascinating space where health information exchange lives. The download is part of our external offerings. It is the sort of why and how, these big topics, and then bits and bites, which we have coming up on October 30th, is usually the partner to the larger topic presented at the download. Next slide, please. Thank you. What if there were an entity that was nonprofit, that was not wholly controlled or owned by any one organization or sector, any one government entity, any payer, any hospital system, any health system, any provider? What if there was an entity that sat in between very powerful organizations doing really, really important work, whose sole purpose was to take information and data from these disparate sources and share it with other sources caring for the same individuals? Well, we don't have to wonder, because in our state, this exists. We are MiHIN. We are a nonprofit organization, an unbiased data trustee. We are the pipes through which valuable, useful, and potentially transformational information shall flow legally, privately, securely, technologically, between disparate systems of care, all around, all being patient-centered, all around who any one patient, any one human being has an active care relationship with, who they are trusting to take care of them. Next slide, please. MiHIN has been in Michigan since 2012. We continue to sort of grow and scale. We sit between the federal government and state governments, our health department, health payers, health systems, prepaid inpatient health plans, and the hospitals and clinics and providers and hospices and FQHCs, and the doctors, the nurses, the care managers, the social workers that are using all of this information to make better decisions about business and about care, about treatment, payment, or operations. At this point, we have around 45,000 providers who rely on our pipes to deliver the information that they need to take better care of their patients. We have about 13.1 million unique patient records, unique patients' information that is flowing through our pipes. And today, we are going to be discussing, next slide, please. Today, we're going to be talking about our MiHIN's social determinant of health use case. And if you've been here before, you understand how MiHIN works and what use cases mean in our sector. This is, for what purposes are we exchanging what information or data about our patients? And today we are going to try, if we can get connected, we are going to try to dig in to the sort of whys and the whos of our social determinant of health use case. Our next offering, like I said, our bits and bytes, will be more of like the how and the what and the technical side of these specs. But for today, we are looking to, hold on one second, we are looking to Van and the head of our cross-sector data sharing program, Lisa, to give us the highlights.
Good morning, everyone. Well, firstly, thank you for taking time out of your busy lives to be with us this morning. My name is Van Lee, and if I were able to get on camera, I would. It's not letting me, but anyway, I'm the product marketing manager lead for the social determinant of health use case. I've been with MiHIN for over 3 years now and have been in healthcare for over a decade now. My background is in health information technology, in practice transformation, supporting value-based delivery models and quality measurement. And I'm here today to share what MiHIN is looking forward to in updating our SDOH use case. If you can see, the title is version 4. That V is version. We're going to talk about the evolution, reasoning, and the rollout for version 4.
Hi, how are you? And I heard Van going on. I heard all of it. I was there. Just could not. I was there as a participant. Maybe I should just stay there. I don't know.
No, do your thing, please.
Hi there. I know Van's already introduced himself, and thank you. My name is Lisa Nicolaou. I am the cross-sector data sharing program director for the Michigan Health Information Network, and I know it's a mouthful. But we wanted to be really, really super duper clear as the terms get floated around, the SDOH and all of that other good stuff. We wanted to be super duper clear about our role within this space. And that is to move that data in these cross-sector spaces, which are not traditional medical care, because they all and understand what data is important for that sector to be able to do the work that they do that may be hiding out in a silo somewhere. So really understanding how all of this fits together for the purposes of care coordination and for aggregating data for better decision making. And ultimately, when we're talking about social determinants of health and health equity, we're talking about how to spend scarce resources in the best way possible to get to those outcomes. So that is our cross-sector data sharing program. So thank you all for being here. We have a lot to discuss, so I want to move forward if that's possible. So next slide. So our agenda today is going to be pretty broad. And again, Joanne kind of highlighted, this is the who, what, when, why, and where. Not so much getting into the technical details. Join us. We'll give a high-level overview of those technical changes that are coming down the pike. Our bits and bytes will follow up on that. So we're really going to follow kind of what is the current state, what is why the buzz, kind of what's the evolution of this specific use case, and what are the changes, what's coming down the pike, and why as we move forward. Some changes to our legal data sharing agreements. And the overall direction of this whole space. Next, and we want to leave plenty of time for questions, comments, because this is about you folks. This is about how we are here to help you in some of these changes. So feel free to jump in. I am very, very bad at monitoring the chat. Please, Joanne's great.
I got you, Lisa. Yep. I love the chats.
Okay, so next slide, please. So we talked about this just a little bit earlier, but let's reiterate. Why are we even looking at sharing social care data? What's the purpose? Where is the value in all of this? Ultimately, we have humans that we have to be able to identify those needs and connect them with resources within the community to be able to help those needs be met. We understand that social determinants of health play a much larger role than assessing and diagnosing and treating medical conditions. We want to move upstream. We want to prevent those diseases from happening. That's where people achieve health. That is the primary purpose. That is what drives it. Okay, but just like within medical records, way back when medical records were brought into space, and the evolution of those medical records, we want the data because that data helps us understand and improve the care that is provided, to understand where we invest scarce resources for maximum impact to those individuals. So that's that second level purpose, to assist payers and policymakers. The US spends just a ton of money per capita on healthcare, more than any other developed country. And yet we have health measures, health outcome measures, which rival that of third world nations when you factor in socioeconomic status. Health equity. we talk about this elusive goal of health equity all the time. Health equity is impacted by power, wealth, and resource distribution. So what we really have to do is understand and make conscious choices about where those resources are best spent. If we want to change things long term, we have to have the data to substantiate it. Long-winded, but that's really where we are going with this, and how the nation is moving in this, which is good, because up until now we have not been all that curious about our social care structure. So this is progress. Next slide, please. Nice. I apologize for my bark. So MiHIN's use case. This SDOH use case. Social determinants of health is a very, very broad subject matter, right? Means a lot of different things. There's a lot of different variables. We want to be really clear that this specific use case is about social needs screening data. It identifies whether or not there is a need present. It identifies whether or not there was an action initiated, and this aligns with the HEDIS measures. This is a foundation. This is not the end point. This is not all of the data that there is. This is the start of it all. The Gravity Project, which you'll hear a little bit more about later, that is a standard setting body. From the early days of when we first started to do this work, there were no standards. We have come a very, very long way in a short period of time, because this data represents a very meaningful, potentially meaningful, transformational set of data. It is the foundation on which to build those other data sets. So if we start with screening, that is the data that we have right now. We have standards for that. We are working on the next wave with referrals. How do we move people in a standardized way to or from community without creating more silos? The social care vendor referral platforms, they do a good job, but they represent silos. And people within the community use systems of record already. So, everybody joining one is not really an option. Moving on to what was done about that social screening, about that need that was identified, and what impact did that intervention have on outcomes? All of this aligns with the evolving data models that are built on co-designed care models. That is something that is unique. Dr. Klinkman, who is our consulting medical director, is actively engaged in leading those co-design sessions. In the past, there has been, maybe a more healthcare-centric role in the development of that. They are actively engaging and revising that care model to reflect the reality of what social care is. I would envision that 90% of people operating within traditional medical spaces, if you said, how does social care happen? There'd be a big question mark above their head. What we're trying to do is understand that and build a care model and a data model that is reflective of reality. Next slide.
Okay, Julie.
This is a busy, busy slide. What you really want to see is what we just talked about. These are building blocks. They build one on each other. And that gets us to a social care record, so that we have, kind of like we have now, with a broad look at all of the different parts of an individual's healthcare, and it's all contained into a healthcare record. We have that capacity to be able to do that within social care as well, to get a holistic picture of that individual. So the important part is, this is the beginning. They are building blocks that are coming along. And the other piece of this is to understand that healthcare's role within this is not to manage the whole thing. It can move from healthcare to social care to social care. And then how do we tie it all back together? So these are building blocks. Next slide. What's driving this movement? I think that we understand, we have a very, very different disease burden than what we did 50, 60, 70 years ago, when the medical model of care really was, we were solving for things like, people aren't surviving surgeries because our surgical technique was not very good. We didn't have the right antibiotics. We didn't have the, the massive innovation that really happened within surgery and medical care. But we have a vastly different disease burden now that those things are very much quality controlled. So the next big level of disease burden is really based in lifestyle. It is based in how we live, and our social determinants of health dramatically impact that, upwards of 60 to 80%. So that is the need. Okay, we have to address a different set of problems. We always have this elusive goal of the triple aim in healthcare, now the quadruple aim, and I'm sure we're going to move up from there. But we want to impact our healthcare space. We want to impact and make sure that people, our citizens, are living healthy and well lives, that we are not spending 20-25% of our gross domestic product on healthcare to achieve subpar outcomes. We want to do this and not crush our citizens with the weight of the healthcare system. And we want to do this while preserving our healthcare teams that deliver care. And when I say care teams, I mean healthcare teams and social care teams. Driving that is also payment model reform. The invention of accountable healthy communities really kind of said we have to get after this. And the good news is the data that is stemming from this is pointing us in this direction. So while long and torturous, it is moving in the right direction. COVID obviously shone a great big spotlight on the health inequities that exist, that have been resistant to that quality improvement process as we quality improve medical care. What we are doing is starting to move outward from there. We are starting to recognize the value of collaboration with our social care partners. There are measurement drivers that are driving this as well. The NCQA and HEDIS measures and promoting interoperability, meaningful use work is all driving towards that cross-sector space. And underlying all of this is these persistent health equity gaps. We want to spend resources on things that make the greatest impact on those health equity gaps. Next slide.
Anybody have any questions so far? Lisa, I just wanted to give you a chance to
A breather?
breath. Yeah. I'm also putting all kinds of stuff in the chat.
Great. I'm ignoring that.
That's good. Ignore it. But for our participants, a link to the Gravity Project, and also a link to our to last year's download where NCQA came to talk about their social determinant of health, new measures. Anybody have questions so far? Please feel free. You can write me. Does MIPS fit into quality measures for social determinants of health, Lisa?
Yes, it does. There are MIPS measures that focus on social needs screening. It's slightly different than the HEDIS measures, but the changes that are coming in this next iteration will help meet all of them.
Awesome. Okay. Nothing from the peanut gallery. You may continue.
All right. I'll try to go slower because I get very passionate about this work. This is all good stuff. Be really, really curious. Throw up your hand if people have heard of the state innovation model. I'm old as stinks, and I remember these days. I remember our MyPick days, but not everybody does. So the first time that social care, this link between healthcare and social care, and the focus on this, and specifically on the focus on finding a way to get to the data of it, really occurred during something called the state innovation model. And the state innovation model was an 8-state, federally driven test, an innovative test to figure out how this could be done. And like a lot of things, when you're being innovative, you make mistakes, okay? And here in Michigan, right or wrong, no standards really existed at the time. We developed a homegrown screening tool. That was the very, very first iteration of the MiHIN use case. They turned to a resource that already moved a lot of data within the state and said, let's try this. So that use case was specific to the state innovation model that used a homegrown Michigan screening tool that was mandated, and it was to be able to ensure that there was a way to be able to aggregate it. So within the state of Michigan, at that point in time, for that specific purpose, that was a standardized model. The problem is, once that state innovation model ended, there was no really, guidance on this. People who were involved in the state innovation model often hard-coded that tool into their systems of record. That was like, that's what they had. That's what we did. Great. There were two legs of that. One was our community health innovation regions, affectionately known as the Shires. And they were really the community version of that. They were the link. How do we create this link? That was driven largely within those community health innovation region spaces. And they were not only just charged with, here, can I get this data back and forth? Can I act on it and get information back? But they were really charged with, hey, how do we move upstream? How do we prevent this stuff? And our community health innovation regions have done a fabulous job of being able to take that data and move things within their own community to move upstream. If you have never read the evaluation summary that came from the state innovation model, I really challenge you to be able to go back and look at that, because there were cost savings. There was good information about kind of best practices. There were a lot of things that really found success. So those things continue, but how do we scale it? How do we scale beyond regions? So post-SIM, there was recognition that a one-size-fits-all tool, like everybody couldn't use Prepare, because it didn't fit every space. So we really needed to be able to allow organizations and to be able to select kind of how they wanted to screen. There was no specific, like, hey, these are the tools there were already validated tools. There were already codified tools out there, but nobody said, hey, this is where you get to pick from. So MiHIN's use case was really refined based on end user feedback to allow kind of that variety, while still capturing that domain level, meaning food insecurity, housing insecurity, homelessness, while we were still trying to get down to kind of those core standards. There was a hint that, codified tools were coming down the pike. We allowed that to evolve. You've been allowed to kind of use LOINC coded tools. There have been a couple of organizations who have done that, but there was very, very little uptake until January 2023, when somebody finally stuck their neck out at a federal level and said, aha, this is how it will go. And those HEDIS SNSE measures, once they went into place, it provided that legitimate, clear guidance where MiHIN can say, okay, we now have a standard that we can align behind and not try to predict where we're going. So that was a really good thing. And over the course of the summer, we have really worked to be able to kind of build consensus that, yes, this is a good thing. We have to be able to align behind it, but we understand fully that this represents a very big change for many of you. I think it's important to point out here that social needs screening, there's more than social needs screening that is done within healthcare. Healthcare, we have increased over the last year and a half, thanks to the Blue Cross Blue Shield incentives. The amount of screening that is going on within healthcare, that really directs us to kind of 15 to 20% of the population that have needs within that space. I think it is important to note that screening is not just done within, or problem identification is not necessarily just done within our healthcare spaces. Screening or problem identification that is done within community spaces may hold even greater valuable data, because that is where people go to seek that help before their healthcare problems become so substantial that they end up crossing paths with the healthcare space. We have a vulnerable portion of the population that will not cross a healthcare space until it's too late to actually do something about it, to the point where we are preventing emergency room visits or surgical procedures or any of that space that is much more costly. So that represents a big shift, is how do we understand and be able to bring in that data from community generated spaces in a legal and ethical way. Next up.
We have some questions going on in the chat. Just a
Great.
couple of questions about, Lisa, you and I were talking about this co-designing, a co-designed care model. So what I did was not great, but I pointed to all of the thousands and thousands of people that are working within Gravity at the project on the community, just all of the different entities involved. I didn't know if you had any more to say about co-design. And then there was also a question specifically about the HEDIS SNSE measures. And I posted about what I think they are in the chat. But Melissa, did you mean what are these specific measures, or what is HEDIS? It's too difficult to follow what the speaker is saying and follow the conversations in the chat. Okay.
Let's deal with the chat stuff towards the end. So point taken.
Okay.
Should I just keep going?
I just want to make sure, Melissa, before we move on, are you asking what the HEDIS measures are in general, or what they are specifically? Because we're going to keep referring back to them. I think we'll hear.
Okay.
Thanks, Lisa.
I'm going to keep rolling. I think everybody wants to understand, why are these changes important to make? I think that part of what we've talked about is, before there were no standards, we have standards now. We have to align with those standards. Michigan adopted this work early. We were front runners, and we still are front runners in all of this work. But part of the thing about kind of being a trailblazer is sometimes we make mistakes, and this is something that we have to self-correct for. Standards are available. We have to align behind them. Post-COVID, that increased attention, I think everybody, I feel it as not just kind of the head of this program, but I feel it as a patient. I feel it as a mother. We got to do something about this, and this is a real path, a real opportunity. So there's a significant opportunity to highlight the value that social care entities bring as it relates to our health and well-being. And we really want to create that level of sustainability and resources to meet the demand, so that we can eliminate those health inequities. I think the biggest thing is, everyone that I talk to believes it's important. We don't want to leave people without care to meet those social related health needs. If it is important to identify when individuals have unmet social related health needs, then it is important to be able to use that data. And in the state that it is in, we cannot use that data. That data is not machine readable. It is not aggregatable. It is not interoperable. So we have to be able to use what we have to move in that direction. Next slide. Talk a little bit about this, right? Two different sources. So it's important to understand that community is a care partner in this work, and the data that can come in from community can come in and be able to be utilized. We have to meet community members where they are. I think if any of you who are old like me remember the first days of kind of, what's an HIE? Well, what do we do? What are standards? Healthcare has gone through that journey. We are bringing our community partners into that journey. And there's mistrust. Healthcare does not have a really stellar record of doing the absolute best thing to help. So there is a little bit of mistrust that we have to be able to overcome. I remember being in a primary care space, and there was all of these same questions surfaced in primary care when we went to kind of send off our data into the stratosphere. But as a result of being able to do that, the quality improvement has really pointed us in a different direction, and that is a good thing. So we are trying to meet our community partners where we are as MiHIN, as the mover of the data. We want to partner with them. We have to meet them where they are at. So we have simplified. This is something that I think is important across the board, whether we're talking about healthcare partners or community sources of data. Not everybody has legal staff standing at the ready to redline legal agreements and make sure that everything's T's crossed or I's dotted. We want to ensure that everyone has access to this data. It is in those smaller spaces where we get after the most vulnerable populations. And that's what has been, that may have been missing. So our simplified legal data sharing agreements are a very, very good thing. There are 2 implementation guides. So we will have a community implementation guide as well as a healthcare implementation guide that is specific to this, because how the community wants to be able to share that data and what it can be utilized for is very specific. Next slide. My partner in crime, Van Lee. Come on, let's talk about Gravity Project. We'll go from there.
Sure, and I see some comments around what the LOINC codes are, so I'm hoping to maybe cover some of that during my portion of this presentation as well. But thank you, Lisa. For those that are not familiar, as a steward for effective and scalable interoperable data exchange, MiHIN is deeply involved in many of the national collaboratives and working groups that support this work. For SDOH, that national collaborative is called the Gravity Project. I highly recommend that you all look them up later. They have a great deal of information publicly available, and they're a great resource for questions about what SDOH domains are, which LOINC codes are associated to specific domains, etc. Just moving along, the Gravity Project themselves created a self-assessment tool that enabled organizations to determine where they are in their SDOH HIT maturity tier. Briefly, Tier 1 means that social risk data inclusive of screening, diagnoses, goals, and interventions are documented in a structured manner. Tier 2 means that you've not only adopted gravity-vetted data terminology, but that you're also exchanging that information within established data transport mechanisms, such as HL7, CDA, Direct, etc. And then Tier 3, you're fully on their FHIR SDOH implementation guide. We're not going to go into FHIR today or in the Bits and Bytes series, but that's coming in the future. But if you want to click through, please, I think I have a couple of animations. Click one more. Perfect. Thank you. MiHIN, back one, thanks. MiHIN is in Tier 1 of the model by adopting LOINC codes, as Lisa had mentioned earlier, and capturing screening intervention information in its SDOH use case. Next slide, please. A few highlights of what's changing for those that are already participating in our SDOH use case and on our version 2 and 3 of our specifications document. Version 4 will aim to refine fields to simplify and clarify data requirements to better the data validation processes. As mentioned before, we're moving towards the LOINC coded screening responses, and we're adding a requirement to include at least one of the following fields: phone number, SSN, the final 4, and address to better our patient matching processes at MiHIN. And we're going to eliminate information previously requested from the SIM project and the Z codes. Ultimately, this gives us better ability to move towards the tiers 2 and 3 of the Gravity Project that I had shared previously, and better align with the HEDIS measure for social needs screening. And just finally, before I move to the next slide, I'm going to plug our upcoming Bits and Bytes webinar on October 30th again, where we will aim to go into more of the technical updates. So please do remember to register for that one when this one wraps. Next slide, please. Gravity and LOINC have a list of what they call approved screening instruments, which I'm sure our current SDOH use case participants are aware of. But for those that are not yet familiar or looking to create social needs screenings, we're just providing here a short list of those approved tools here. The LOINC codes all map to these assessment questionnaire questions and responses. So it is really important to also note that as SDOH domains are added or are refined, I would expect, and please do expect, that this list will grow. Next slide, please. So just a short preview of our Bits and Bytes series. I'm going to walk you quickly through what a LOINC-coded screening example would look like. And this is all available on LOINC's website. So you can actually search for this code that I'm listing here and you'll be able to find it. But for the question, for example, of within the past 12 months, you worried about that your food would run out before you got money to buy more. That LOINC code in particular is 881227. The 96778 that you see above is indicating what tool you're using, and below that full list that you see there are the codes that are adopted, are the actual questions codes that are adopted by LOINC. Next slide, please. And here are the related LOINC code responses. So for example, if the answer to that previous question is often true, sometimes true, or never true, the mapped LOINC code are listed under the answer ID. So for often true, that code is LA28397-0. Obviously, this isn't something you would show to the patients, right? The LOINC code. This is again for machines to be able to be interoperable and a part of our exchange. And I think the next slide we'll get into the timeline. Right, next slide, please. Yep, which I'll pass back over to Lisa. Thank you.
All right. So we're coming to kind of like the close. There's a lot of questions. I want to get to them. Key timelines. There's a lot of work that has happened already in being able to move this forward. Up until now, we've done a lot of consensus building. From this point forward, this is our first venture. This is like, hey, giving everybody the awareness that this is coming down the pike, meant to inform about the V4. We know that there's going to be increased coordination with account managers and our team. Our door is open. If you have a question, email me. If you want to book some time with me, I have a Calendly thing, book some time with me. We recognize how much of a change this will be for many individuals, and we want to ensure that we do things to assist and simplify this process as much as possible. The other thing that is really important to know, we have a lot of file specs out there because of this evolution and because of this constantly changing process. There is a version 2. We have, I think, 2 organizations that are still using version 2. There's no additional people will be allowed to onboard to version 2. No additional organizations will onboard to version 3 2021. There are organizations, there are incentives out there. If organizations want to onboard to version 3 so their incentive structure can get up to date, great. You can still use LOINC codes in that version 3. There's going to be a difference. You have to be aware that if you're onboarding to it, that version 4 is coming down the pike, and make decisions based on what you know. Starting January 2024, we will have a finalized version 4 spec. We have a draft. Our goal is to have that draft up and on the website by next week so that you all can take a look at it. When I say we want to finalize it, how software is developed, how kind of technical changes are managed are really very much, we can set all the standards that we want. We have to go through that development process with those programmers. Those programmers we go through something where we kind of sit and we hash it all out and we come to, this is what we're doing. Now we're developing. When I say it is high level content, we understand what that content is going to be, but we want to wait until that opportunity to move with the programmers to 100% finalize that spec. So that will be out in January of 24. But the high level stuff, you should be able to get a really strong understanding as to what those changes will be and start your progress towards that now. July 2024, version 4 will start to be accepted. We have a lot of organizations to move from previous versions to new versions. That has to happen before December 15th. Let's face it, nobody wants to be doing this during the holidays, and we want everybody converted over before January 2025, when no other file spec will be accepted. I know that that puts everybody into what are the changes? what we think is going to happen is it's going to simplify what is going on. We are looking to simplify the data intake. We are looking to get rid of a lot of those extraneous stuff. Next slide. How does this impact submitting organizations? Obviously, there's been a lot of investment already, and we get it. We understand it. I worked with organizations to be able to do some of those changes, and change is really, really hard, especially in this healthcare environment. MiHIN really wants to be here to help and guide that work and to support that work and help you through that process. We understand that this is a high priority because value-based payments are dependent on this use case. We understand that when money is on the line, it is a big deal, and we want to really make this a smooth process. Next slide. What are the next steps? If you are not registered for, please come to the Bits and Bytes on October 30th. We're going to be able to get more in detail about that, the technical stuff, more tools available to help with that transition rollout. In terms of what you're doing now, if I were in a screening organization, I would want to understand, what are my questions now? And are they from a validated tool? Are they close to something that is from a validated tool? Understand that you do not need to use one single tool. What happens is they're all codified. If you like a food question from a Prepare tool, but a housing question from a WellRx tool, and the AHC tool for utilities, you can do that because they are codified, because they are validated. It's the codes that make that happen. There are lots of, if you have things that were homegrown, what looks really, really close, switch to the validated version, start that process, get that in order. Use the Gravity tools to assist. We can help with that. We can point you in the right direction. Identify what those codes are and map those codes. Remember, you can submit those codes now. And then start to compare using that draft file spec. What are we doing now? What needs to change? How will we move forward? And reach out. Next slide. Okay, there's a lot of questions going on in the chat. I want to let's try to get to some of those. Joanne, can you feed them? Because if I try and do it, it's going to slow us down.
Yeah, absolutely. Okay, so let's see. I think we stopped around here. How is, okay, so Shannon is asking, she's working for a different MCO than she did when she participated with the Shires, and she is wondering, how is the screening data being shared with payers? Or maybe related to this, is there an SDOH use case participation list available?
That we have an SDOH use case. Remember, there's inbound and there is outbound. We could provide a list of who is submitting data right now. Up until now, and again, you've got to understand kind of the data that's stemming from it. Up until now, what has been shared is really the payers have the legal right to that data that is produced within healthcare is able to be shared with payers. We are working with payers right now to move that data up. Up until now, it has sat in data banks and gotten to mass adoption. So that is starting to happen now, where that data is being shared with payers, specifically Blue Cross Blue Shield, because they are incentivizing that use case. Up until now, we have provided a report that allows them to administer their social needs screening incentives. But yes, payers will be getting that data and they will subscribe to that data feed.
Shannon, does that answer your question? Let us know. can you give an example of community data? Would you be considering data from state and local health departments, such as unemployment or WIC, bridge cards, programs? Is that the type of data that we're talking about here? Because this person, Lindsay, says that she would think that many people in the population would be uninsured.
Yes. These are all kind of new use cases. They are not the data that we're looking for coming from this specific use case. But yes, in terms of a cross-sector data sharing program, we have a lot of spaces that are dealing with things like social care. We have schools who readily identify social related health needs and try to solve for them. We have health departments that are doing this work. But we also have different needs stemming from community, and understanding what those needs are and what data that organization in the community may need in order to do their job effectively helps us develop new use cases. Does that answer the question? So I guess
so right now for this, yeah,
I don't necessarily know what you as a community organization need. Be happy to have that conversation.
I was thinking also maybe Lindsay wanted to know, like right now, local health departments are not, as far as I know, aren't sharing their social determinant of health screening with us.
Not yet.
Okay.
No.
All right, we went into some of the LOINC codes, and the LOINC codes, like we said, we will be moving more specifically into that in bits and bytes. We are up at 10 minutes left to go. There is a lot of, let's see, a lot of people using Epic. We use the SDOH screening released by Epic. Will large EHRs switch to new questions and answers? You know, Epic has this SIOH screening tool. How does that translate to these codes? A lot of people are wondering, you know, look, we have this stuff built into our EMRs. Is what's built into our EMRs what you're asking for?
I think that is a question. I am not in charge of Epic. I'm sure Epic is well aware as to what data standards are out there. And again, you know, problem with kind of going in advance is that you might miss something. So I would definitely verify what questions are being asked, identify whether or not they are validated tools or a validated question, a codified question, and does that question stem from one of the approved screening tools.
Similarly, let's see, Michigan Medicine uses the same screener. I have a question about screener and whether the screening tool will close the HEDIS SNSE gaps. I don't think it will, since I don't think the questions come from one of those approved screening tools, which is sort of like what we had discussed. And what Michigan Medicine is using for their screening tool was based on what they were told and asked to do in the state innovation model, which was where we started. The questions and the questions that you all will have to ask and the information that we are suggesting that you send to MiHIN will have to be different.
And I do want to mention, again, HEDIS is asking for also intervention information as a part of the measure, as well as requiring that you look into the exclusions. So I think it's important to note that we're aligning with HEDIS as it pertains to the questions and answers, but you know, we're not calculating your HEDIS score, right? That's not what this use case really is about. This use case really is around promoting data interoperability and sharing of that information with the key stakeholders who work on that social risk screening.
Cerner's SDOH prepare form. They just started using this. Maybe nothing's being submitted to MiHIN. This is an interesting question. Is this a requirement that we need to get set up with this? Let's talk about people are not, there is no
There's
requirement.
no requirement. There's no requirement for this. This is, do you see the value in it? Is there financial incentives to support that work? Because I think everyone involved, payers, understand that this is added work. There's no requirement to send this data. No.
Trevor, you had asked a question specific to, are we saying, is MiHIN saying that if an entity does not use one of the approved screenings, that they cannot submit screenings in the SDOH use case? Are we saying that now? Will we say that in 2025?
In January of 2025, that is correct. Because, and again, I come back to the purpose of this data. It's, if you as an organization want to just continue to kind of quality control things from within that silo, within your organization, that is your prerogative. MiHIN, as a data standards organization, must align with those data standards. Now that data standards exist, we have to be able to do it. If you are doing something that is text-based and is not using a codified tool that is approved, then you are outside of those data standards. That is your prerogative. You may continue to do that, but in order to maximize the best use of scarce resources, we do not want to continue to flow data that is not aggregatable and is not usable.
Working. What about ICD-10 codes? Are you only using LOINC, NOPE, K, or Z?
We are only using LOINC because that is what the Gravity Project standards and the HEDIS measure standards are directing us to do. When we start getting into ICD-10 codes, we move out of screening and into diagnosis. That is a secondary level survey, and you may still, ICD-10 codes are billing codes. You may continue to submit those billing codes to your payers on your claims. That is completely fine. But in terms of data standards that identify screening and observations about an individual, that is a LOINC code.
Is there work underway to create a SNOMED value set for individual SDOH answers for items such as food insecurity or housing? The available list is pretty broad right now.
Yes, I believe that the Gravity Project is considering LOINC and SNOMED CT, and they are working on that. Is MiHIN specifically? We have representation at these at that level. We are not specifically setting that standard because we are not a standard setting body.
Oleg back before wanted to make the note also, and I think we heard this in our pre-registration questions about the need to clarify ethnicity and race codes used in SDOH reporting. Do you want to just touch on that?
Sure. So ethnicity and race codes are a big deal. We can say that these are the standards that MiHIN is accepting. What is being submitted is not necessarily the most accurate and up-to-date information. Again, this is a process change within our systems of record to update to the most current ethnicity and race standards. I would argue the same thing is coming down the pike for SOGI data, but we accept the most recent standards in our appendix, and in our tools we provide you with that link to what those current standards are for race and ethnicity as set by the CDC.
Thank you. Chris, I think she's trying to clarify. Chris Elliott is trying to clarify. So payers are receiving patient-specific data with patient name?
They will be receiving that because that is according to treatment, payment, and operations. That is not a MiHIN decision. That is a HIPAA decision.
Yeah,
if they have an active care relationship with this patient, the data will flow.
And
right,
that
it's
is
only
from
for their patients. Yeah.
And that is from healthcare generated sources.
Will MiHIN share SDOH data from mental health agencies? MiHIN will share social determinant of health screening from any entity and any organization that's submitting it in the way that, in the way that we're asking them to.
Again, there has to be great understanding as to, is the mental health care space healthcare? Is that
Right.
community space? If an organization submits data to MiHIN, we have other projects that are going on, quality improvement projects under the Health Equity Project, where that data can move up solely for the purposes of for that level of analysis and not go to payers under a treatment payment and operations organization. But if an organization has a treatment payment and operations relationship with a payer, that is HIPAA data that has to move under treatment payment and operations.
We have 1 more minute left. I'm going to do one. Trevor is asking, so I think we just touched on it a bit, but we were talking about some legal changes and some legal modifications so that community can start to participate. Do you want to say anything more about that?
That this is in piloting form. We have to understand what is the capacity for community-based organizations to be able to submit and engage in data sharing legal agreements and the costs that are associated, so that we can understand and better be able to prepare organizations for those data sharing opportunities and escalate the barriers and problems that exist to higher organizations like our CIE task force who are dealing with these issues.
There was a question about cross-referencing between ICD-10 and LOINC.
One is an observation code and one is a billing code. They are not equatable.
Okay, it's 11. There was
I'm happy to stay on and answer questions.
Right. If anybody wants to stay, you've got the right people. We will be moving deeper into the actual specification of the files that we are asking people to send at Bits and Bytes on October 30th. If your questions have not been answered, please write to me directly and we'll get them answered. Stay right here. We'll keep it recording for everybody who wants these slides and these recordings. Bring it on.
And I have to use this opportunity to drop. So again, I'm the technical person. So go to Bits and Bytes on the 30th and hold those questions till then. But feel free to reach out to me as well. I'll put my email on down here as well.
Okay, thank you, Melissa. I'm going to write to you. I'll write to you directly with Lisa's contact information. There's Van.
It's also on the slide deck.
Yep.
Great. Cheryl has said we've been directed to use ICD-10 codes, probably because LOINC codes were not yet developed. If we start submitting LOINC, do you know if the plans will accept those for measure compliance, or will we continue to have to submit both, one code for MiHIN and a different for the plan?
Again, the plans are going to be very, very interested in those HEDIS measure compliance. There was a huge kind of like, what do we do on plans? Obviously, really kind of like the billing codes are a big deal for them. You can continue to submit that in your billing codes, but in terms of they want those LOINC codes because they also have to be able to meet those HEDIS measures. Again, the argument about do we use LOINC or do we use ICD-10 has been settled by someone else other than MiHIN, and the fact that someone has put their neck out on the line takes that question out of our hands. If you want, do they have the ability to come off mute and just talk? I'm happy to have those conversations. I'm a talker.
Looking.
Lots of folks still on the line, please.
Hi,
Diane.
Lisa, can you guys hear me?
Yes, we can.
This is Cheryl from Michigan Primary Care Association.
Yes.
I just want to make sure we're directing our health centers correctly because we've been collecting data since the SIM project, and we've expanded on that.
Yes.
And we have, our clinically integrated network that we have plan agreements with.
Mhm.
But I guess my goal then is to educate centers and get their EHRs set up so that when we, for the most part, use Prepare, when they fill out their forms or their templates, that we can capture those associated LOINC codes. And so when they're connected to MiHIN, they're sending data. So you would capture those LOINC codes at your end. And unless our supplemental data file is coming from MiHIN, which I think at least one is, then we would still need to, the plans will accept the LOINC codes. I guess that's what I'm getting at.
We have worked with the multi-payer group. We are aware that different plans have different requirements. We are trying to move them in the same direction of a standardized set. That we are working with that multi-payer group to ensure that we direct that all towards that SDOH use case. If they are getting that in a standardized way, it takes you out of the equation to have to send different files to different places. It reduces your barrier.
And are the Medicaid plans part of that multi-plan group?
Growing, yes.
Okay.
And Diane Marriott, are you still on the line? Diane Marriott leads that work. We have worked very, very closely with her, as well as our MDHHS team, who I do see on the line.
Yeah, I think Diane dropped, but certainly she was very involved in this, and we will get her the recording, and if we need her, we've got her.
Yeah. Speak up. I will stay on as long as need be.
We've still got 63 people here, so if there are,
There's got to be some questions.
what are you wondering? Right? What are you wondering? Right. Should payers be educating providers to start using LOINC codes?
Payers can do it, but that's kind of what we are doing right now. Spreading the word is important. Yes. I mean, I think now that standards exist, we have to all align behind them to make the best use of that data and the work that goes into collecting that data.
I'm looking around. Dr. Kevin's here. Chris Elliott's still here.
Chris Elliott, did that answer your question? And what reservations do you have about that? You asked the question about PHI level data.
Right. Patient name and patient SDOH. We've heard many reservations, Chris, about this, and it's okay to hear more. And specifically, most of it is coming from community, which is why we want, we're trying to create parallel paths for information that is being generated within healthcare, and then information that originates and generates from community.
So there was a question in here from Melissa. Can you unmute yourself? I love talking with people. Providers, that's what this use case does. When you submit those codes to MiHIN, those codes, the payers subscribe to that use case as well. to identify who their acres population is, who do they serve, and then they get the information from providers who have also contributed to that data that goes up based on that, their population. So that's how those LOINC codes get to the payers. You as an organization don't have to go here, Blue Cross Blue Shield, here, you know, and attach it to your claims.
If you're sending to MiHIN, MiHIN is sending to any organization that has a legal active care relationship with that patient. So that any of the LOINC codes will be getting to the payers through MiHIN.
And this includes, so what this also does, there are organizations out there who may want this data. As accountable care organizations grow and understanding kind of your full population, if organizations do not have that inherent capacity to aggregate all of that data for their population, it may benefit them to pull that data in to their own tool from across the space. If a primary care provider is screening once a year, but you know the patient is hitting the ER and they're screening in the ER, is that data valuable to understand at a primary care level or at a population health level for those accountable care organizations? When we have all of this data that's floating out there in text-based fields, it is not aggregatable. It is not machine readable. So when we get to that level of data, we can then say, is this data valuable to anybody else aside from payers? Is this data valuable to a primary care organization? Is this data valuable in population health management within provider organizations? Is this data valuable to understand when you refer someone to a social service provider, to understand more than, let's say you make a referral, you screen somebody positive, is that beneficial to somebody who's already been, that same individual who's being treated by the Area Agency on Aging? Is it valuable for them as they look to help meet their social care needs? Okay.
Dr. Kevin raised his hand.
Okay, Kevin.
Let's do it. Maybe he didn't mean to, because now I don't see him.
Melissa, I see your things. Open door, open email box anytime. My phone number is there as well, and I will take your phone call.
Oh, I do see Dr. Kevin, but I don't know. Maybe he can't get off mute.
I think that there is something with like not being able to. Oh, there we go. I'm trying to talk, but I must be muted. Kevin, I'm so
to
sorry.
unmute. I just asked him to unmute. Let's see. Did that
There
work?
we go.
There we go.
Oh, hey, you can hear me now.
We
Hi.
can.
Can you hear me now? Yay.
We can.
So
we
I
can.
got a message that said if I hit *6, then you could hear me. So maybe that's just a little lesson learned. You know, after 3 years, we haven't figured out how to do Zoom, I guess. Yeah, so, I mean, Joanne, you just had a leading question, of course. Do we need this data, or do we need to close the loops on referrals? Do we need, the answer is yes, right? So the actuaries, I believe, in a conspiracy-laden thought, actuaries for all the payers, they want to know this stuff because they can then predict how much the costs are going to be, right? So why would we not also want to be privy to some of these data that are being collected? And maybe that's a self-fulfilling prophecy of everybody getting more data. But for that, the answer then is we're going to have better population health decisions that we make for the people that we're serving. And so if you look at, you know, MiHIN as an entity that's supposed to be for the health of Michiganders, then of course the answer is yes in terms of sharing, but for the purposes of recognizing PII or PHI, you know, and I've had those conversations with Mike Klinkman and others, the biggest aspect to that really is consent.
Yes.
And that, I think, is the biggest aspirational aspect of full visibility And right now, I'd say patients probably aren't familiar or aware of how much of their data are already aggregated and shared around. But when it gets down to that micro level, they then start freaking out. Well, I mean, we're in a space to overshare, I suppose, but let's be honest, also with the payers, they see that there's a need out there. They're not satisfied with how we're managing a certain population. They hire a vendor, and that vendor goes into their homes and starts talking to them, even though we as a primary care doctor or healthcare system didn't sign off on it. So we have lots of data being shared that's unbeknownst to our patients already. They just don't know it. And so this level of sensitivity of consent and how things are shared, I think needs to be blown out of the water and shared much more in a transparent way for patients to know that their data are already being leveraged for the purposes of cost and insurance interests. What we need to pivot to is the clinical indication of why, if we know that information, they'll get better care and better coordinated care between all the entities that are well-meaning of how to keep them healthy and or allow them to at least continue to live out in dignity with the services wrapped around them. There's my sermon. I don't know whether that answers your question, but I mean, those are the drivers that I see as a healthcare system leader.
Agreed. And I look daily at kind of like cloud-based everything in outside of healthcare. And I look at the amount of data that is being flown through about me personally out in the World Wide Web. And yes, I think it scares a lot of people. But I think that there is a balance to be achieved. And I think that the transparency is critical.
Right. We're just at the beginning of it. People are going to start to understand that their cars are sharing information about them, that everything that they carry with them on their phone actually gives people a different picture than the information that, that is being legally regulated and shared. So we're just at the beginning of this.
Yeah, and that balance is interesting because we have to say, we have to consent out of love and earnest interest in their well-being and couch it in that perspective more than feeding some actuary.
Yes.
Because, this gets potentially parental. I don't like using the word paternal because sometimes my wife is more strict with the kids than I am. So then the nice guy is paternal instead of maternal. We kind of go back and forth on that. So if we're parental as organizations and we say, not what you're doing, we know better, here's a service that you need, that's part of the need for sharing information, is just trying to do those wraparound services that even patients might not be aware of that exist. So as you're pointing out, like the Area Agency on Aging, maybe they know how to build a ramp to somebody's home with 3 steps, but that person's sitting there in silence and thinking they have to sit in a nursing home for the next 2 months when there's a organization ready to build a ramp and they can get back home.
Yes.
Right. So you know not what exists out there in terms of the CBOs that do really good work. So, dare you dream to share information, not suffer in silence, and cry out for help in a good way. And that's the ultimate purpose, right? So we just have to figure out how to frame those asks for both the information and the consent to share so that it's done in a well-meaning way and not seen as some sort of oversharing that makes people think Big Brother's watching them and somehow has a nefarious agenda that isn't otherwise centered on their goals and their patient-centered approaches.
Yes.
And I actually think that the way that MiHIN has set up and based our work on active care relationships and is really setting up for consumers, for patients, for humans to start asking themselves questions about what information they want to share with who, when, and why, and for how long.
So Acre's definitely the platform to do that. I will say there's a caveat to the selectivity of sharing information, where I've run across this in one of my relationships with a federally qualified health center, where there's sensitivities for certain diagnoses and, dare I say, even medications. So somebody who's on Suboxone or methadone or something, everybody would know where that leads down in terms of assumptions that are made. We have patients that, unbeknownst to them, a medication list is available as a broader list, that they then get freaked out that the ER doc or somebody knows that they're on a medication that they hadn't otherwise shared in another setting. Okay, well, people, I will be now more parental here and say, I need an up-to-date, accurate med list, period, dot. That actually might be one of those things that you're not allowed to, line item by line item veto as to whether it's shared or not, because that's actually a patient safety issue. So just like vaccines, there may be things from a consent that we really need to say that's a non-starter for refusing in terms of sharing. And I don't know whether MiHIN has wrestled with that for your use cases and what can be shared and such, but like for those sorts of things, it actually could result in a bad patient outcome. If an ER doctor or primary care specialist saw a patient, didn't realize they were on a drug, prescribed something, there's an interaction. Now it's, because a patient was freaked out about sharing, they now have something that bad that happened. So I really think that there's got to be a balance. And yeah.
And I think
This
that
is a fun chat. Oh, I saw Melissa Kirshner out there. Hello, Melissa, you're out there too. Cool. I can't see everybody that's on.
I do want to make sure that for the vast number of people who have been willing to stick around, that we are still getting to any questions that are outlined that you still have related to what was talked about today. I know that we did not kind of give you everything that is coming in our bits and bytes in just a short period of time, but what other questions do you have? You're sticking around for a reason.
I have a question.
Yes.
And I know that you guys want this information, but how are we training, I guess, the medical assistants and all these different lower level care providers? Because truthfully, a lot of the times it's something that people don't talk about, but yeah, we could tell providers, hey, we need this information, but when you give it to the person that's going to actually do it, they sometimes don't feel comfortable, or they just don't want to ask. And then that becomes a barrier.
Can you talk a little bit more about that and what creates that level of uncomfortableness?
Or like, where do you work? Let's start there. Like, what setting are we in?
So I'm actually I work for the payer.
Sorry, I'm having a hard time hearing you.
So I work for the payer.
Okay.
Great. So, but I always put myself in the position of other lines of, work. Like if I'm going to be a medical assistant, how do I approach this member? How do I talk to these members? I'll even take it into consideration when I go to the doctors. They don't barely ask anything. So it makes me think, are they being told? And if they are being told, is it that they're not comfortable asking, or they're not sure how to bring it up?
I mean, there are best practices out there as to how to engage in starting this work. I think organizations that were involved in the state innovation model certainly, and I think there was, the CARE, Chris Elliott helped me out with what the name of that organization was, that as screening was kind of starting to pop up, there were pathways out there that, described, like, how do you change your talk? How do you start that to manage that change? And as a nurse, I can tell you that even before the state innovation model days, even before all of this, we understood that kind of understanding, hey, we're very interested in kind of helping you be successful at being healthy and well, but there are things that get in the way of being healthy and well that may not be medical related. we may not be able to address them by ourselves, but there's services out there to help that. You know, do you have a problem? Are there issues with your housing? Do you have problems getting food? I think when you take that approach that there is more to health and wellness than medications and surgical procedures and diagnosing, that it's bigger than that, and we understand that, and we are part of a collaborative team, health and social care well-being. I don't know that anything will ease that level of uncomfortableness until you practice it, and until you believe that you're actually trying to get after and connect people in need with resources. It's not just a check the box thing. Does that help? Does that hurt?
No, it helps. It's just one of those things where it's like, these are some things that providers have to take into consideration once they start, implementing and talking to their staffs.
Yes. And I think that, the screening aspect, especially within healthcare, has been around for some time now, and they're starting to do research studies on, whether or not patients feel it's weird to, why are you asking me about my housing? What are you going to do about it? Patients are actually starting to normalize that conversation because it's been around. I think sometimes because it's new to us, we may think that it's abnormal for them. It's kind of like, I'm going to equate it to talking about death and dying, like patients are very aware of it and they're very willing to talk about it. It takes a long time for providers to get comfortable about talking about it.
One of the really interesting takeaways that I had from the state innovation model was how many people came through and were screened and had multiple needs. So they had multiple needs. And then the last question that was asked was, can we help you with these? And so many people said no. Like,
and
we don't want your help.
Right.
We have these needs. Can you help me, or do I want you to help me? No. Which is why having having a support system within the community, or somebody that they do feel that they can share these, concerns with and ask for help, connected to a larger, picture, that's why.
Well,
That's
there's a huge difference between sitting with a patient, and not everybody has, the ability to sit with a patient and ask these questions in detail. Sometimes we just hand them a tablet and say, oh, check the box, do whatever. There is a huge difference between, hey, there's some questions, that conversation that we just had about, there's more that helps us keep you healthy and well than what we could provide for you. Sometimes just a simple statement like that, could you fill this out and can we talk about that when you're done? It allows the conversation to continue and evolve, and nobody's going to say it's perfect. We don't have all the answers. Nobody does yet. But the more we talk about it, the more we progress, and we do it collaboratively, the better off we will be.
And on that note, 11:26. Thank you for sticking around. We will look forward to Bits and Bytes. Our doors are open. Our phones are at the ready. Call us, write us. Let's meet up. We're here. Thank you for coming. We'll see you soon.
Cheers, folks. Thanks for your time.
Thanks,
and
Lisa.
for your work.